Welcome to another episode of the Hack My Age podcast. Before we get started, I just want to remind you to please leave a review. I know I keep drilling this into your head, but it's super important to go onto Apple Podcast or Spotify or wherever you listen to your podcast, give a rating, hopefully 5 stars, maybe 10, whatever the option is, and leave a review so that the podcast can grow. We're really, really working on growing the podcast so that we can get more great guests for you and just highlight the importance of menopause. The other thing I want to remind you is by now we're in full swing of the Biohacking Menopause membership program. So if you're not part of that yet, please join. It's such an amazing group of women. I absolutely love these people. They're super supportive. So go check that out. The links to that membership group is in the show notes. Now, before we get started the show and the introduction of Dr. Debbie Rice, who's our guest today, I want you to just to remind you, this is what I try to do for every woman I speak to is to empower herself with information. So be open to lots of things, listen, but always be a little skeptical, right? That's everything that I say as well. Anything you hear from my guests, anything you read, even the studies that you may find and read, just have that little bit of skepticism in you. But the biohacker in you may decide this is appropriate for you, not appropriate. It's something to try or not to try. That's for you to decide. So this episode was all about critical questions in terms of testing, and particularly the Dutch testing, which we'll explain what that is when you listen to the episode. But it still left me with questions and doubts. It's an episode that I wish I had both sides of the arguments, both sides of two people, maybe a three-way for it to really hear a lot of the sides. But I've come up with my own conclusions as well, which I'm going to share a little bit. So to get you up to speed on this sort of testing your hormones, but there's a lot of other testing that comes with the Dutch. We didn't discuss in the episode the cost. We kept saying, oh, it's expensive, not expensive. But just to give you an idea, what does it mean expensive? It ranges, there's different types of Dutch tests. It ranges from $299 to $700. Okay, that's in my mind expensive. The $299 is a cortisol one. It's all you're looking at. And then the $701 is for the cycling woman. You're looking for PCOS, who has PCOS issues and fertility issues. Usually in our menopause space, we're talking about the one that's $499, and it's called Dutch Complete. That's the one that's quite comprehensive, lots of information in there. But keep in mind, not only are you paying for this kit, you're also paying for a doctor to interpret it. Although there are some people that do it, that do the reading for free, and they will sell the test, because usually you have to go through a practitioner, not always, to actually get these tests, and there's a cost. Sometimes there's sometimes there's a, not a cost, it's a discount for you. So what I've learned through my exploration with the Dutch is that there is an agreement, there's an affiliation between Dutch and a practitioner. And I don't know what the commissions they get. I think it's 10% or something. Sometimes the practitioners are just not interested at all in the commissions, and they just pass the savings on to you. And some don't. And then some may even put on a charge, an even higher charge. So it depends probably on the doctor you have, and you can ask these questions to your doctor, right? So no, don't be shy. And that's the cost. We're talking about cost. That's why it's so expensive, and you may want to do it only once a year, if at all. Okay. There's also something to keep in mind, that there's restrictions to selling the kits. If you're in New York, Rhode Island, and Maryland, I don't think you're allowed to sell it. We didn't discuss this in the podcast, but keep that in mind if you're there. And then if you're international, like me, not in the US, or not in Canada, then it's pretty complicated to get these things. You can't just deliver them. Some countries you can, but the ones that I've been in Europe, they would stop the Dutch test at the border, saying that this is I'm not allowed to receive it, and send it back. So if you're in Europe and you want to get a hold of this test, I know that nordiclabs.com will sell it. However, they don't sell it just to anyone. I think in the US you can go online and buy the kit as a client, as a patient, but you won't be able to read it unless you are trained, because it's quite difficult to read and to interpret. So in Europe, you will need to have a practitioner order it for you and then send it to you. And then you send it back. You pee on the sticks and then you send it back. So it's a little complicated wherever you are. It's not always easy. Sometimes it's simple, sometimes it's not. And the one big question that you're going to be asking yourself after you listen to this podcast is, do I need a Dutch test? Should I do this? And honestly, it depends. And it's absolutely not necessary to do a Dutch test to treat menopause. There's even, I don't know if you follow Dr. Jen Gunter. She's quite big on Instagram, and she's a board certified gynecologist, and she wrote this book called the Menopause Manifesto. She's really adamant. Like, you'll see stuff online like totally trashing the Dutch. And she says the Dutch test is clinically meaningless for menopause and should not be used to evaluate menopause status or to guide menopausal hormone therapy. In fact, no hormone testing is needed to guide menopause hormone therapy. This is not just my opinion, but the recommendation of the major medical societies. To an extent, yes, I agree. It's not necessary to treat women and prescribe them hormones and understand what's going on. You can go a lot by their symptoms. But if you want to look at metabolites, if you want to see how those hormones are converting, it's the only way I know. Now, whether that's necessary or not is up to you and your practitioner. And so I believe for myself that perhaps it may be a good thing, which is why I do the Dutch test. I think right now you could argue this till the cows come home. It's kind of like, really, when it comes to testing, it's you gotta talk to your doctor. You have to listen to your practitioner. And it really, these tests are not only about sex hormones. It's not say, oh, do you have progesterone, estrogen, testosterone? It's likely you don't if you're in your 50s, or if you're not bleeding anymore, if you're having a lot of hot flashes and symptoms. You don't need to determine, you don't take any kind of test to determine that you're in menopause or perhaps perimenopause. So, but these tests are really not just about those sex hormones. There's so much else that's going on there. And we'll listen to the podcast, you'll hear us talking about it. But that is the question. Is it, it's not necessary to treat the menopause, but the training that I have done with the Institute of Bioidentical Medicine, and I learned from Dr. Rosensweet, Dr. David Rosensweet, who's been treating women for 30 years, that as a practitioner, as a doctor, he wants to see women in this Goldilocks zone, is goalposts that he's come up with. And he's figured this out because he's tested so many women, and where they're feeling well and where they're not feeling well. And he's looked at the research, and he's saying, what is the research showing as how much of our sex hormones do we need to be protected in terms of the brain, the heart, bones, etc. And then how much is actually too high of a dosage. And so this is where he does a lot of his interpretation through those metabolites. And you're going to learn, if you're not like, what is a metabolite? We're going to listen to the podcast. You'll understand that more. But that's why in the end, I would say your practitioner, you have to ask, what are they comfortable with it? If you want to read an article that is kind of the opposite side of what we just discussed, because of course this episode is with a practitioner who's associated and affiliated with Precision Analytics, who's created the Dutch test. So of course, we'll hear her side. But the other side, completely the opposite, is an article by Abby Langer Nutrition. you can, I'll have the link to that blog article so you can take a look at it. I have my own arguments, but again, I just want to empower you with all sides of the story, because there's a lot of noise in the menopause space about the Dutch, and so you go, well, I want to do it, but it's really expensive. And what about those people who cannot afford that or is just not ready to put down that kind of cash? Well, we have alternatives. Okay. I don't believe that you need this to help you through menopause. If you got a little extra cash or you have some money cashed away for your health and you really feel more comfortable doing that and your practitioner is all on board, then yeah, why not? You're not going to get hurt by doing it. So I would say whatever your practitioner is most comfortable with, but also if you're working with a functional medicine doctor or menopause doctor, you have to make sure you trust that doctor. Are you 100% confident that that doctor knows what they're doing, that if they like this testing, awesome, but beware of those doctors that are upselling you to everything, to gut testing and toxicity testing and all the hormone testing. And so do you really need this? Do you not? Then they try to get you some IV drips and then they're selling you supplements, and be especially aware if it's their own brand of supplements as well. Not to say that they're bad. I mean, sometimes practitioners come up with their own formulas because they can't find what they're looking for. But it's always, again, keep a little skepticism here and just ask yourself, do you really trust your doctor? Are they really comfortable with this? Because I don't think so many doctors would be so on board with touch testing or the other alternatives as well if they didn't see value coming from it. If okay, they make 10% commission, even if that were the case, I don't think they would really be using this. There's so many other things they could probably take a commission on than this. So if they're really gung ho about it, they really feel that it's practical and it's useful in their practice, then okay. But if you can't afford it, you've got to really use your voice and say, this is just not for me now. What is the alternative? And the other alternative is blood testing, saliva testing. And again, it's not just about sex hormones. You also want to look at DHEA, the thyroid, and a full thyroid panel if you suspect you have thyroid issues. SHBG is sex hormone binding globulin. You may look at your hormones on the blood, but that'll be a total testosterone floating around, but sex hormone binding globulin may be sucking up all those, all of the testosterone that's there and not letting it run freely in your body. Insulin levels, HbA1c, CRP, inflammation markers. There's so much more that you can test. And it's not, again, you're having menopausal symptoms, and based on the symptoms that you're giving to your doctor, they may suspect, okay, maybe hormones are not optimized, but maybe it's a thyroid issue, or maybe there's some blood sugar issues. Maybe there's something else going on, and that a Dutch test is not necessary for this, or certain blood work is not necessary for that. There's also saliva testing, which if you're testing cortisol, a lot of doctors prefer the saliva. Um, so, all of these testing, it just may help you figure out really what's optimal for you. Where is your optimal level? Because the range, if you're looking at blood serum levels of certain progesterone or estrogen, that could be so like the range is so big in perimenopause that, and especially if you're taking the hormone therapy as well. So you got to figure out when do you feel best and what is the safest space for you. Other dried urine tests, if you want to compare to the Dutch, are Meridian Valley. Genova Diagnostics also does some. Then there's the 24-hour urine test. I know Dr. Rosensweet likes Rhine Labs, and you'll learn about what the difference is between the 24-hour urine test and dried urine test in the episode. That in itself in the US costs $339, so it's not like it's a whole lot cheaper. And that's not even quoted on the website. That's just, you have to sometimes ask for that. And that was what was quoted to me. Then if you're in Asia, like New Zealand and Australia, there's something called the Eve test. There's another website called ZRT, and then when you do these testing, you got to figure out what days of your cycle to do them. If you're still cycling and have a period, usually it's day 19 to 24 of your period, depending on how long your period is. So you'll learn a lot in this episode, but these are just some of the things we didn't talk about and I wanted to add on to as well. And there we go. So my message to you is to be open, do your research, and always be a little skeptical. Now, the introduction, let's introduce Dr. Debbie Rice. She is the Director of Clinical Education at the Dutch Test, and she has a practice that's focused on hormones for both men and for women. And she has an interesting background. We didn't even talk about this in the episode. She used to work with the Peace Corps and Natural Doctors International, and she has a really special interest working with underserved and diverse communities. And she studied naturopathic medicine at the National College of Naturopathic Medicine in Portland. And she's done special training in women's healthcare and midwifery. Dr. Rice is excited to help her patients not only feel better, but increase their quality of life as women are living longer. And she has loads of work waiting for her as the population is aging, right? So lots of work. Now, there's a disclaimer to the podcast, as we always do. Usually it's at the end, but just to remind you that our discussion does not merit medical advice and is for educational purposes only. So let's get started. Today's episode is sponsored by the Institute of Bioidentical Medicine, which is the authority when it comes to understanding bioidentical hormones. And I just completed their menopause method course, and I am mega impressed. This is a self-paced course designed by Dr. David Rosensweet, who's been treating women through menopause for nearly 3 decades. And I can highly recommend this program, particularly if you're a doctor or someone who is actually prescribing hormones to women for menopause. So make an appointment at iobim.org to see if you're a candidate for the menopause program and ask for a discount with the code ZORA, ZORA. You're going to learn so much with this program because menopause is inevitable, but suffering is optional. Okay, well, it's a pleasure to have Dr. Debbie Rice with us today to talk about hormone testing. Welcome.
Thank you. I'm excited to be here.
So let's first talk about hormone testing in general during this perimenopause and menopause phase. So on the podcast, we've heard, at least on the Hack My Age podcast, we've heard some doctors say it's absolutely essential to test our hormones during this time and other things as well. And we've heard other people say testing is a waste of time and money during this perimenopausal period. The hormones are fluctuating like crazy. And I understand both arguments. So
Mhm.
taking into consideration full transparency that you are
Yep.
employed by a hormone testing
I'm a Dutch
company,
I'm a Dutch girl. Yep.
the Dutch test, the precision analytics, what are your thoughts around some of these controversies?
So and it's a great question, right? Like to test or not to test. And when we are perimenopausal, I think it also depends on where you're at perimenopausally. If you are still cycling, but things are just feeling different, I feel like that's a great time to test because it gives us more information about what's happening with your progesterone and your estrogen. How variable are those levels of estrogen for you? Are you still ovulating or not? Right. So that's where like early perimenopause, I think can be really helpful with testing. When you get into the perimenopause of like, well, I had a cycle 3 months ago, haven't had one since, I'm not quite sure what's going on. It's like if we test, we're probably going to get really low progesterone. Who knows what the estrogen's going to be? Probably on the lower side. So we can assume that you're going to have lower levels. Postmenopausally, we know that your ovaries are not doing anything, right? So we know that your estrogens are going to be postmenopausal. We know that your progesterones are going to be postmenopausal. So I think, and there are some people that, prior to starting hormone replacement therapy, we want to know what their baseline is, right? There's that curiosity of like, well, where was I before and where am I going to be? Like, where am I now? Where am I going? But perimenopausally, when you're still having cycles, you're still having more predictable cycles, I think it's really nice to see what the variability of those hormones is. So I would say in that I find utility in testing in the more early perimenopause, and you could certainly test the later you get into perimenopause, but I don't know that you need to.
Mm. So just to clarify for some people, because I just said testing in general, and I'm talking about both serum testing and urine testing, saliva
Mhm,
testing, I guess, but I'm speaking mostly to those two, because
mhm,
first of all, a lot of people don't know about urine testing for hormones and the
that's true.
metabolites, which we'll explain
Yeah,
in a moment, but
yeah,
the blood work, yeah, it's such uh gosh, it's such a mess, I think, for some doctors to deal with when you're in
yeah,
that phase, because they say you can test in the morning and it'll be totally different in the evening, or you test one day and it's totally different the other. If you're walking into my
yeah,
office, this is an argument, I'm talking about my guests, people I've
yeah,
interviewed, or
yeah.
doctors, or hormone experts or whatever. They would say, "You're feeling bad. I just want to get you better." So, and we
Mhm,
know that you can probably predict that your hormones are going to be up and down. And there's they don't want to waste your money. They don't want to waste your time. And they say, let's just get you feeling better now. And
mhm,
very often it's hormone therapy. Maybe it's
yeah,
something else. Or maybe the doctor says, you know what, you're not feeling bad because of your hormones. You're feeling bad because your thyroid is off. So then maybe you do need
right.
to test. And so again, it's everyone's individual, but when we get, I think a lot of women in this phase that I'm in, I'm 53, I'm still cycling, and it's quite predictable. A couple of times I've taken progesterone too long and it's just no period. And then the moment I
Mm,
stop, it comes back. So I'm still figuring it out.
right.
But when I was
Yeah.
50, I was thinking, this is 3 years ago, I was like, I think I need to explore a little bit more about these hormones if
Mm,
this is right for me. And so
mhm,
I can understand the woman who's listening to this for the very first time, and what we do when we go into the doctor with, like, anything else. Like if you think you have something or maybe off, we go, well, let's just test. Let's just see where
yeah,
I'm at now. And
yeah,
so when a doctor says, no, you don't need it, I get it. You feel like, oh, that doctor doesn't know what they're talking about. Or you
right.
get scared, like, when are you gonna give me hormones and you don't even know? And so there's this
Yeah,
whole psychology that's behind that.
yeah,
And so I think what doctors need to do is explain a little bit better, not so dismissively about
mhm,
testing, whether it's urine or hormone, but the woman. So if I understood you correctly, because the question I get often is, do I need to test? And if I do, when? And then you stated clearly, like, if you're pre-menopausal, you have regular cycles, maybe it's interesting to test blood or urine. I'm not sure which one you're talking about, but to
yeah.
see what's normal for you. Did I understand that part correctly?
Yeah, getting a really good baseline, right? Like if you are still cycling, and I mean, ideally, like if we took away the whole money equation, right? Like if
Mhm.
we didn't have to worry about money, ideally, we would love to do testing. And for me, I would like to do the dried urine testing because it's more comprehensive. It gives me a lot more information than doing serum testing, which is the blood draw. We like to see that baseline, right? Where are you in your normal and how is your body metabolizing those hormones? And I think what ends up happening for a lot of people is we silo sex hormones and we think it's just about sex hormones. And we're not siloed beings, right? We have multiple systems that are very dynamic. And when we're looking at that, we want to remember that as our baseline too, right? So what are our sex hormones doing? What are our adrenal hormones doing? What are our thyroid hormones doing? Right? These all, I call it the triangle of love, that really influence each other. And the reason why these are important is because your adrenal glands become your second ovaries, right? Like they end up supplying your hormones postmenopausally. So if your adrenal glands are stressed at your best cyclical part of your age, right? Like you're 35, you're cycling, but you are stressed to the max. You are not setting yourself up well to transition into perimenopause and menopause, right? So that's right. Yes, you can test in silo for sure, but is it going to give you the complete picture? I don't think that's a fair assessment. Like if we are really catering to supporting evaluation and supplementation, we can't tear off half of the equation.
Mhm.
Yeah.
Makes sense. Before we move forward, I'm worried about the woman who's listening and going, "What in the world is this Dutch test? What is a dried urine test?" Maybe explain
Mhm.
just briefly what it is, just so
Yeah.
we get her up to speed.
Yep, totally. So, a Dutch test is a dried urine test for comprehensive hormones. That's what it stands for.
It's not to see if you have any Dutch relatives, for
That's
sure.
right. That's right. And what ends up happening is you get these filter papers that look like the size of a business card that you pee on. And you do this multiple times during a day. So a 12 to 24-hour period of collection. And this is usually, dinner time, bedtime, when you wake up, and then about 2 hours later. And you let all of these samples dry and then you send them in. We're able to pull hormones off of that to see what is your overall cumulative range in that 24-hour period of estrogen production, progesterone production, testosterone, DHEA, which is an adrenal and sex hormone. And we also get to look at your cortisol, so your stress hormone. What is your stress hormone doing throughout the day? How is it functioning? Is it supporting you? Do you have enough? We also get to see how the body manages those hormones, right? So when you make this estrogen, where does it go? Does it go down the good pathways or the bad pathways? So that's what the dried urine testing is. And that's why I say it's a bit more comprehensive than a serum draw. That does not mean that serum is not good. It just means there's more information behind it.
Hmm. Yes. Okay. So serum meaning draw, blood test, and
Yes.
Dutch meaning you're peeing on a stick, letting it dry. There's
Yes.
also 24-hour urine hormone testing, which is where you pee in a cup for 24 hours. So
And you
s-
carry that little jug
you
with you. Yep.
you carry the jug or you stay at home, or that's another way of testing, just so women are clear on all these different testing. And they also pull out a bunch of metabolites and information that you wouldn't be able to get in a blood draw. So
Right.
what are the differences in what people are seeing with the peeing in a jar for 24 hours and just peeing on a stick 5 times?
In all honesty, there's not a lot of difference between a 24-hour urine and a dried urine. When we've run the correlations, they are strongly correlated. So we can see if you're going to get this estrogen for the dried urine, you're going to get the same estrogen in a 24-hour urine.
Okay. And are there any price differences? Is this or
That is a
coverage by insurance?
good
One does one and not
question.
the
That's a
other?
good question. Yeah, that's a good question. And I think at least I can speak to the US. Usually with a 24-hour urine, insurance will only cover that if there are significant disease states, right? Like, oh, we're worried that your adrenals are failing. Like, failing, like you might have Addison's disease. So we're going to have you do a 24-hour urine collection. If we're doing like, oh, you're perimenopausal and we want to help you feel better, your insurance may or may not cover. It just depends on how
Mm,
good your insurance is. Um, Dutch does not get billed to insurance, though we do have coverage. So we have a super bill that you submit to insurance for reimbursement. And depending on your insurance, they can cover up to 80% of a Dutch test.
mm. Okay.
So,
Interesting. Yeah, it
yeah.
depends. A lot of things it depend, but that's really good. Actually, there's some will cover that.
Yeah.
And eh, so getting back to when to test, when
Yes.
should we be testing, and what are your thoughts then? So the woman who's going through perimenopause where her hormones are going up and down is quite unpredictable.
Yeah.
You said she should hold off until she's actually more stable to get testing. What? I'm not sure if I understood you correctly.
So when you are in that early perimenopause and you're having predictable cycles, but you feel like, and I get this a lot, where like I'm still having cycles, but they've changed. Like I'm bleeding heavier, or it just feels different. Like my cycle just feels different, even though I'm still, 28 days on the dot. That's a great place to test because then we can see what are the variances in your hormone levels. When you get to that place where you're like, I might have a cycle every 2 months, 4 months, 6 months. It's been 6 months since I've had a cycle. Now, as a Dutch test, again, like if money were not an issue, I would say I would still test because I want to know what's going on with your androgens, which are your testosterone and your DHEA, and your adrenal function. The bonus is that we also get to confirm if your estrogens are low and your progesterone is low. We might be surprised because your estrogen might be a little bit higher than we expect.
But wouldn't it be even day to day different? Couldn't you be having full
It
of
could.
hormones one day because you're still
Mhm.
cycling and then have a surge and then next month, exactly the same day of your period, or even the next day or a couple days
Could
later,
be
you test
quite
again
variable.
and then it's
Mhm.
gone. So
Yep.
that's kind of hard. Then, how accurate can it really be? Whether it's Dutch or the same thing for
Or
serum.
serum. Mhm. Yeah, there is a lot of variability in that, like, later perimenopause stage, and I would say in general, the reason why the society say, like, "Don't test," is because it can be so variable, and you would have to know that going into it, like, knowing if I do this testing, this could change tomorrow, this could change next month. But we also wanna look at your symptoms, right? So, how consistently are you having hot flashes, night sweats? How is vaginal dryness? How is joint pain? How is muscle pain? Are you having headaches, migraines? Like, these are all the things that as a hormone doctor, you're taking into consideration. It's not just the lab values, right? Like the lab values can add value, they can impact your decision making, but it has to be in concert with adrenal function, symptom presentation. What else is going on too?
Mhm. Yeah, and there are probably cases that are a bit harder to crack. Like me, for example, I had no symptoms until just recently started getting a little bit hot at night, but for 3
Mm,
years, nothing, but the Dutch test showed I was, like, postmenopausal, like, all my hormones are
mhm.
gone. I'm like, "How is it even possible?" Like, I should be curled up
Yeah,
in a corner crying, and so
yeah.
then doctors get really frustrated, or confused, or that's when they may go, "You know what? How are you feeling? If you're feeling fine, let's, like, skip this until you start to have something." So there are people like me, I know, who are just we still want to know because we still have some hormones, and then you want
Hmm.
to see how they're metabolizing,
Right.
whether, and then if you're on, and so I've started HRT,
Hmm.
and even with the HRT, it was still 0. And I'm like, well, wait a second, I'm spending all this money. I'm like not absorbing it.
No.
So
Yeah.
and I'm in that post perimenopausal stage. And sometimes I question, like, really, how accurate is this? Because it's as if I'm doing nothing.
As far as the test results
Yeah.
show, it's
Yeah.
like you're doing nothing. I do wonder too, there are some people that and this is why I feel like baseline can be really helpful because there are some people like we don't have the testing to look at estrogen receptors, estrogen receptor activity, like how sensitized your system is to those estrogen receptors. And we have, different estrogen receptors, estrogen alpha, estrogen beta receptors. I would wonder how sensitized your body is to estrogen. Does your body require a lot of estrogen to get that response, or does your body, need just a little bump to get that estrogen
Mhm.
response? And so there is that variability that happens too, which is where, again, like if we could turn back the clock and be like, this is where you were 10
Mhm.
years ago or 8 years ago, right? With how your body was cycling and knowing where that expectation for estrogen is for you, because everybody's a variable, right? Like we're all
Mhm.
individual, we're all unique. And being able to see that comparison for you, I think could offer a little bit more information into that. But I think it
Mhm.
also depends on, are you taking a cream? Are you doing a patch? How much are you doing? And when are you testing? What does that look like too?
Yeah, and so in the end, yeah, my doctor changed. Okay, let's stop with the sprays and let's do a gel. Let's sort of, we're now playing around with
Oh,
different things to
okay.
see until we can get a point where I'm
Yeah.
absorbing it. But the good thing is now it's good that actually I'm feeling a little bit of symptoms. Then I can play around with it myself, and then I could figure out what may be a good dosage for me. Because again, it's so much variability. Maybe, 1 month I need more estrogen. I feel like, wow, I can increase and I feel good. And then the next month I'm like, I'm using the same dosage, and really I'm starting to have more feelings of
Mm,
heat or hot flashes. It's not quite a hot flash, but something like that. So,
just
and
that
then of course there's
warmer.
a lot of stuff that's under the hood. There's things that I even question. There's things that I don't feel. And just because we don't feel something doesn't mean you're not having symptoms.
That's right.
And so that's
Mhm.
why continue to keep working on myself, and not only based on the fact that I feel fine. I want to be optimal. And then, of course, I want to make sure I don't fall into osteoporosis or something.
Mhm.
You just, you want to be at the optimal level, is my opinion. Now,
Absolutely.
some doctors say that is, if you're gonna do a Dutch test, because it's quite pricey, and then you have to pay the doctor to see, and all that, instead of, if you have all the money in the world, great. Do one before, do one after
Right.
you go on hormone therapy, whatever. But they say if you're a bit restricted, then why don't you, if you're gonna start hormone therapy, let's skip the Dutch test or some serum test, whatever. Let's just get you on this. And once you're somewhat stabilized, which may take 2 or 3 months because you have to tweak it up or down
Mhm.
until you're feeling
Adjusting.
better,
Yep.
then
Yeah.
once you feel like you found your optimal dose, then we go and do the Dutch
Mhm.
test or the urine test or the serum, whatever it
Mhm.
is the doctor wants to do. Is that something you agree with?
I think that's also fair, especially if there is that discussion of finances, right? Like when and how to use that money and time appropriately. I would want to make sure that you are at an optimal effective dose and that we can support your metabolism of these hormones optimally as well. So I would agree with that.
So let's talk a little bit about the metabolizing of the hormones. What does that mean? Because that's why doctors who do Dutch testing or 24-hour urine hormone testing, they want to see how the estrogen is converting. Is it going down
Mm-hmm.
safe pathways or
Yeah.
not so safe pathways? And then if they're not going down, if they're not in an optimal safe pathway zone, then there are things that we can do to mitigate any kind of damage or risks.
That's right. Yeah. So, on the Dutch test, because it's a urine test, we are limited to what we can find in the urine. And so that means we're able to see phase one detoxification in the liver and phase two detoxification in the liver. So, our liver is that place where everything goes to get all jumbled up and then cleaned and spit out, right? So, we're able to see that with our estrogen metabolism on a Dutch test. We're able to see how our phase one clears those metabolites. And those metabolites are essentially downstream from the estrogens, right? So when we think of estrogens, we're thinking estriol, estradiol, or estrone. The most commonly prescribed are the estradiol and estriol. And we want to see, does the body make these in good numbers or bad numbers? So are we sending it down the good pathway or the bad pathway in phase one? And we also want to see, once it goes through phase one, are we able to continue to make those clean estrogens so we can dump them? Phase one metabolism is very reliant on, it kind of makes it messy before it makes it better. Phase one makes it messy, phase two makes it better. And so, phase one and how your body's making it messy, are you making it messy for DNA damage, or are you making it messy that's an easy cleanup? And that's what we want to look at, right? Do you have more risk for making those metabolites that change DNA? And those are the more dangerous ones. Or are you making it messy in the appropriate way so that your body knows how to clean that out better?
Mhm.
And that would be through phase two. So that's what we're looking at with our estrogens.
Mhm. So that's what we really like to, that's what's convincing me, at least, and a lot of women going, "Okay, yeah, I'd love to see that." We can't get that in a blood test and serum.
Yeah.
So it's really interesting to see what's happening. So if a woman is, whether or not she's taking hormone therapy, we can see what her estrogen is doing, which pathways are going down. It's not
Yep.
like you have to be on HRT and let's see what's happening. I always think, well, no, you still are making, even if it's low, like you're
Hmm.
still going down some kind of a pathway, right?
Absolutely. Yep. Absolutely.
So, yeah, so my well, I guess what agree is, if you're gonna test through urine testing and you can only get 1 shot a year or something like that, you go and do it
Yeah.
after you've, if you're taking hormone therapy, if you wanna get on it, not to worry so much, especially if you're having symptoms before, but more, take it after you sort of start to feel better. right?
stabilizing that dose and making sure that you're at a good dose. I mean, we have research on where we'd love to see those estrogen levels in serum or blood, and where we'd like to see those levels for a Dutch test, right? And what we mean by that is these are the target areas where we find good bone health support, right? And so then when we know that that's supporting bone health, that's also something that we can look into and evaluate for you.
Mm. So let's move on to the next. I've got so many questions here, and
Yeah,
I feel like
yeah.
I rambled on in the first one. So some of the guests I've interviewed, and we're talking about these doctors I interview are hormone experts, menopause experts, but usually it's the doctors who strictly follow the NAMS guidelines. That's NAMS is North American Menopause Society, and it's actually now converted, changed their name to just Menopause Society.
Menopause.
And the
Mhm.
Menopause Society does not endorse dried urine testing, actually any testing for menopause really. And they
Yeah.
argue that there is no substantial evidence in the literature supporting testing like the Dutch test. And they say there's no scientific evidence showing the effectiveness of it. And then they would go on, to say that the research that they've done, they say the only published science that you can find on about Dutch is something that Precision Analytics published themselves. And so these doctors are just worried that if they were challenged by regulatory boards, that they would get in trouble. That's what they would say.
Yeah.
So they don't use it in their practice. They just don't want to
Yeah.
even go there. So what would you tell these guests that I've been having?
Yeah. So NAMS, or the Menopause Society, has made it very clear they don't believe in testing. Now, the technical standard of testing when we look at hormones is generally considered serum testing, right? And when we look at testing, especially if we do serum, and this would depend on, again, some of that variability if you are not on hormone therapy, but we also see when you are on hormone therapy, if you do serum testing, and this is in the research, right? You would have to do serum testing multiple, like every hour to every other hour. So every 2 hours a day to be able to find out what that average dosing looks like for a female on hormone therapy. And when we're looking at that, it's not realistic for someone to go in and do blood testing every 2 hours, right? One, it's probably expensive, and two, it's really not fun. So that is not a realistic way to test and evaluate for hormone therapy. And that's where, yep, I agree with NAMS on that. What I would also say is when we look at a Dutch test, what we would clause to what we would, give for offering to NAMS is in a Dutch test, we are able to get a 12 to 24-hour pooled value of that information, and it's easier to collect, and we get a more average representation of what that estrogen can look like. So there is that's why we would encourage testing, because you're not doing serial or repeated blood testing to be able to find out what that average response is for hormone therapy. We can do that in dried urine over that cumulative period and get an average. Now, in speaking to the regulatory boards, absolutely, what we could do with that is you still want to back it up with serum testing, right? If you're going to do a Dutch test, you're going to look at the levels, you're going to look at the metabolites, you want to confirm it with a serum test. And that's where you would be able to support any of the questions that you might have with the regulatory board, right? Like standard of care says serum testing is the way to go. So we're going to
Mhm.
do that, but we're also going to expand that with something like the Dutch test.
Yeah. And so, but what about, I'm just thinking what they would argue, probably what they would say is that, yeah, you can do 24 hours, but you do it the next day or the next week, it's not going to be the same. So then I think that's what their argument is.
Is the
And then
variability.
well, yeah, it's just the variability,
Yeah.
but that's why you
Well, and
meant,
this is what
yeah.
I would say too, is you don't just make one decision off of one testing result, right? And the reason why I say this is because if you have somebody that comes in with thyroid issues and you start them on thyroid medication, you're going to retest them, right? And you're going to retest them and you're going to retest them. Why? Because you're trying to find the average of what's happening with that therapy. And that's the same idea where it's not just one and done in testing, right? So that's the other consideration there. Like you wouldn't do that with thyroid testing. You wouldn't do that with insulin testing. You wouldn't do that with any other kind of medication. Why would you do that with sex hormones?
Hmm. Hmm.
So I think that yes, there is variability, absolutely. And what we want to do is make sure that we have a couple of results to look at to see where that variability lies and how we can support that best.
Yeah. To me, it seems, yeah, if you're in this period of life, we have to maybe just go in with it saying, okay, I know it's not like 100% accurate. I know there's variability. It's just going to be one piece of the puzzle among other things that my doctor will use
Absolutely.
to help me feel better and to feel safe, right? Because
Yes.
there's just been so much damage done with the Women's Health Initiative studies scaring women on hormones, and it gives you cancer. I
Yes.
mean, it's dangerous. And so, of course, we walk into the doctor's office like with our knees shaking and like, "Oh, should I do this? And
Yeah.
please test me to make sure I'm in a safe zone." And
Right.
if, it's
Yeah.
just, I think we don't we don't seem to walk into the doctor's office with the same thing asking for birth control, right?
That's
It's
a great point. Yeah.
like, what,
Yep.
why don't we have, and we actually should be concerned going in with
Right.
control, and we don't. But that's the damage that's been done. It's what it's a, oops,
Yeah.
I got my microphone stuff. Sorry, my microphone unplugged.
Oh, you're
Yeah,
fine.
that's the damage that's been done. So we have
Yeah.
to, yeah, just keep educating ourselves and getting through this, right?
Yeah. Yeah. And that's where I say too, like it also depends on where you're at in that perimenopause to menopause journey as well.
Mm.
Yeah.
So let's get a little bit into the science of the Dutch because some guests I've talked to have thrown out some things to me, such as the Dutch doesn't have the quote unquote gold standard of testing like the 24-hour urine hormone test, which uses GC mass spectrometry and this is just to identify the hormones and get those exact molecules. So you can see those people I'm interviewing, maybe more biased towards that testing. And so when you test with the GC mass spec, that's just a way it's used for, I guess, a lot of other things, such as, just
Hmm.
drug testing to see if they're
Hmm.
therapeutic or if you're overdosing and you're abusing it. And
Yeah.
so I learned that the Dutch test uses LC mass spec. So
Hmm.
what is this mass spec? What is the difference between the GC and the LC?
So it's my understanding, and we're looking at the difference between GC and LC. When we're looking at certain hormones, it depends on how well we can isolate those hormones. And the LCMS that Dutch test uses isolates those hormones really well. So what that means, how that translates, is even at levels, say for a postmenopausal female that has really low levels of estrogen and really low levels of progesterone, we are still able to isolate those hormones and accurately represent them with an LCMS. And so there's a difference with the GCMS and the LCMS and how they're able to separate those molecules, right? Like that's essentially what they're looking at. There's a liquid chromatography and a gas chromatography. The GC is the gas, the LC is
Hmm.
the liquid. And so that's how we are able to separate out those certain proteins or molecules or see, this is where I'm not a scientist. A scientist would be like, that's not the right word. But in that sense, we're able to isolate those hormones really well and accurately represent them well. That's the whole point. We have expensive technology so that we know that what we're telling you is accurate.
So I wonder
And that,
then why, if it's true that, say, GC gas is the gold standard, then why
gold standard.
wouldn't the Dutch use, why is they using liquid? I'm wondering why they wouldn't go with that.
So I would say this is a change in kind of technology, right? Like as technology gets better, we adjust to that technology. And this would be for, I'm going to use an analogy. This would be like saying if this were a smartphone, GCMS is like using iPhone 1,
Hmm.
where the LCMS where we're at now is our more current version.
Mm. Okay.
So depending on timing and when, this information was gathered, and that's not to say that 24-hour urine is not good. I think it depends on what you are testing.
Yeah, and maybe the 24-hour urine test is liquid, right? Like
Hmm.
it's not dried, and the Dutch test is a dried hormones on a piece of paper. So I guess perhaps the extraction is, yeah, I guess maybe that's the differences, but it'll be interesting to dive a little bit deeper into, yeah, I'm gonna keep this question too in a pinned so when I get
I was
some of
gonna say
these.
because I feel like this would be an extension to something else that you want to ask about, like how we pull those hormones. Because when it's on the filter paper, it comes to us dried, but it's reconstituted into liquid urine, and we pull that.
Mm.
And so
Yeah, that
that is how we pull the information.
so that's another argument one of my guests would say is, that Dutch is making an assumption that this spot testing, every 5 times a day are close enough to the gold standard for practical purposes. And then they would go on to say that when they try to find out, what's going on, Dutch just it doesn't give an exact number for each spot, and I don't know why that is. And so they'll say that an algorithm is made just to give us some kind of a number. So is this true? And then, like, what is this algorithm based on?
So my question is, one, I don't know what they're talking about with spot testing. Are they talking about doing a certain time and that's what we're testing?
I think they mean that when they say spot, I think they mean that the 5 time, 4 or 5 times a day, we're peeing on a stick and or
Hmm.
peeing in a cup, putting the stick in and letting that
Yeah.
dry. And I think that's what they mean by spot, like taking certain
Instead
times
of
of the
doing the
day.
full 24-hour urine and doing like
Yeah.
the 4 or 5 times throughout the day. So there are studies, not just our studies, but there are studies about correlation with spot testing, dried urine, liquid urine, and correlations. So there are studies that support that. And there are
Mhm.
studies that support any of the algorithms that come with that. So it's not like we just magically came up with a number and decided that that was it. Like all of this is well backed by research.
Yeah. You would think. I don't know where they're pulling this stuff out, but yeah, you would think. But yeah, it's interesting how they say that. But let's move on to more arguments that I've heard. Um,
Sure.
yeah, they say that the about the Dutch test that there are huge marketing dollars behind it, so that it gets a lot more distribution than may other tests that some doctors would say. They say there's maybe more science and transparency behind them. What are your thoughts on that?
So I honestly don't know where they would get that information. We do the same type of marketing that any other lab does, right? And if we're talking about marketing, going to conferences, all of the other labs are also there representing their test. All of the other labs are doing the same things that we are doing. And some labs, I think, are doing it better, right? Like there are certainly things that we could do. We I don't think that we have this big, huge marketing push that is different than any other lab. Now, are we unique? Absolutely. Can we support that uniqueness? Absolutely. But that's not because we have secret millionaire funding that supports our marketing. That is not the case. And there was another part of the question that you asked.
Oh,
Sorry.
yes.
Um,
I'm trying to think which one is it? Is it the one extracting all the hormones from the paper? No, it's not that one.
um,
Oh, yeah. No, no, no. No, I think that's a different question. I've got all the questions here.
okay.
I'll move on to that one. I want to finish with
Okay.
this one, because it reminded me of other dried urine testing. There are competitors. I think it's Meridian Valley is one, and it's a very similar process that you pee on on these pieces of
Mhm.
paper and dry them and send them
Yeah.
in. And then there's another one I can't even remember the name. And what are the differences between all of them?
So, in all honesty, I don't know the exact process for how they would do it. I would imagine it's very similar. Um, but I think when we look at like even our competitors, they do not have the same kind of research that we have.
Mhm.
And my question on that would be if there is concern about legitimacy coming from other competitors, we're the ones driving the research behind it and
Mhm.
trying to like show that yes, we are a valid testing method. Yes, this is the research that we have showing this, right? Um, I don't see that research in other labs.
Mm.
We're kind of
I'm wondering,
trailblazing
do you
that.
know how long these other ones have been on the market? Maybe there's a difference as well, how long they've been around.
The Meridian Valley has been around a while. Genova, the doctor's data is newer. And our owner, Mark, who is the president, he is the scientist, has has worked for a couple of different lab companies as well. And the reason why he started Dutch was because he believed that this was a really great way to represent hormones and hormone therapy, and he wanted to make it bigger. So the, this is where it's not like this was just kind of thought up of like, oh, we're just going to try to do this. Like these were ideas discussed in other laboratories as well.
Hmm. So, okay, actually, I think this is the question that we were thinking, alluding to. So, because you mentioned Mark, is that Mark Newman?
Mark Newman is our president,
And he's a
and
scientist,
creator,
yeah.
founder.
Yeah, because there's another argument that I had that and the accuracy of the Dutch testing, and so uh some of these doctors would say, oh, well, if you go on PubMed and you can see that there isn't anything that's not funded or in the interest of precision analytics. And so I went on myself and just kind of
Mhm.
looked at a dozen studies more or less I pulled out from PubMed and from the Dutch website as well. And I looked at them, and most of it is done by Mark Newman and Desmond Curran. So my question was like, who are these people? So you've answered one of
Yep,
them, Mark.
yep.
And maybe I'm missing the research that I'm looking for. So are you aware of any of the research that hasn't been done and with any conflict of interest?
We do have some more studies besides the ones that I think were just found, but I would agree. Like, of course, we are going to be the ones trailblazing, like trying to show that our research and our what the data that we have is valid. The encouraging thing behind that is that we are getting picked up by other journals and prestigious studies so that they are confirming what we are trying to show validity in.
Hmm. So actually, it'd be great if you could share with me later some of those
Yeah,
studies, and I'll put them in the show notes.
absolutely.
And then if
Absolutely.
anybody challenges me again, I can say, what about these studies? Like,
Yes.
and there's more
Yeah.
coming,
Yeah.
I guess. Right?
Yeah. Yep.
Um,
Absolutely.
yeah. Okay. Okay. So we've covered that. And what do you think of this? The in terms of peeing on a piece of paper, and
Mhm.
some doctors would say, well, there's such tiny amounts and so you can't be really accurate, and they'll call it poor scientific technique. It reminds me a little bit sometimes when we do our biological age testing or some of these home kits, and you just take a
Mhm.
spot of blood from your finger, you
Totally.
prick it, and you're like, well, how accurate is that? Like, shouldn't I go get a blood draw? Like,
Like how much can they pull
how
from
much
that?
can you
Yeah.
really get? And so then when they pull out this argument, I'm like, well, yeah, that makes sense too. Like, why peeing on this stick? And shouldn't we just be paying in a cup? And how much,
Yeah.
yeah, how accurate
So,
is this?
yeah, and the reason, I mean, really what shines for, I think, the dried urine testing is that you don't have to worry about liquid urine. You don't have to carry around that liquid urine jug. So it becomes a little bit more convenient. But we're able to pull, like kind of as we alluded to earlier, we're able, like once you have all that dried urine, you send it in, we're able to extract that, right? Like we're able to reconstitute it, extract it. And that gives us at least 8 mils of urine to be able to work with. And the only time that would be an issue is if somebody's not able to fill the filter paper,
Mhm.
or that's where we see issues with that, or if there are kidney problems and it messes up um how the urine itself is able to put proteins down. But it's never been an issue of being able to pull and extract the urine to be able to get those hormone and metabolite levels.
And are they going to be, I'm just trying to think of the concentration of it, because when you say 8 mil, if somebody's peeing in a cup, it's like a liter or something, or 1,000
Hmm.
mil. Um,
Hmm.
8 mil is enough compared to I guess if you were to ship 1,000 milliliters of your pee to somebody.
Yeah, yep. We're able to pull that information. We're able to get that information. And in seeing the correlative studies, we can see that that information is represented in the studies too.
Okay, so yeah, you said you could do head to head, yeah, dried
Hmm.
urine versus the wet urine, I guess, test. And if
Hmm.
they're similar, yeah. And it brings me to a point. I did the menopause training with Dr. David Rosensweet. Do you know him?
Hmm.
He's
Yeah.
spoken at A4M and he's quite well
Yep.
known in this area. He's a
Yeah.
big fan of the 24-hour urine test. And so I'm like, but why not Dutch? Like everybody's talking about Dutch. And
Yeah.
he said when in his practice, been doing this for 30 years. He's tried them both, and he says he prefers the accuracy of the dried urine, the sorry, not the dried urine, the 24-hour urine hormone test. And so it makes me think, whatever is it better or not better? I think if your doctor is doing anything like that, it probably doesn't even matter. It's like it's good that they're doing something rather than
Yeah.
nothing and to
Yeah.
find those metabolites. And there's no point in me trying to convince, if he's my doctor, convince him, no, no, do the, he's
Right.
used to that. He knows
That's
what,
what I was going to say. It may also be comfort level of what he's been using, how he's been using it, and
yeah.
he's still getting great information, right?
Yeah, and he has these goalposts that he made, like where he's looked at research and he's looked at all the testing that he's done on all these women, and he's figured out that there's a minimum dosage of women to have their hormones at, uh,
Mm.
usually with the hormone therapy. He's a bioidentical hormones guy, and so he wants them to at least be in the minimum so that they get protection of the brain, the bones, the heart, breasts,
Yep.
vagina, all that stuff. Because if he says if you're like
Yeah.
too low, because this is what you can find out with these testings,
Hmm.
whether it's the Dutch, the 24-hour urine, you can see like you may be feeling better, but we're not protecting your future self.
Exactly.
And
Yes.
then the other end of the goalpost is overdosing. And he doesn't want you to
Hmm.
go over because he says, well, we don't really know yet. Like we still are, trying to figure this all hormone stuff out. And so he
Right.
likes women to be not overdosing, even if they're feeling fabulous. Like sometimes he says they're a little bit too high. They're like high on
Mhm.
hormones, and it's
Yeah.
because they're overdosing it. And he
Yeah.
doesn't really want them to be overdosing either.
Right.
So this is why I really appreciate doctors who understand that, not just we don't need testing, we just want to make you feel better. Fine, here, take your hormones.
Yeah.
Okay, maybe we test after,
Yeah.
but I'm a big fan of I like that goalpost, and I did the training with him. It makes
I do
sense to
too.
me.
I
And
do too. And I feel like, I mean, I've had those patients that were like, well, years ago I was just put on estrogen and then haven't had a follow-up. And it's like there's been no follow-up after starting whatever estrogen you were put on. Nope, they just gave me my estrogen and here I am 2 years later. And we don't know, right? Like maybe their symptoms are in check, maybe not. What's happening with their levels? Is it too high? Is it enough? I, I feel like we do a disservice to women when we just dismissively put them on hormone therapy. Like there's a way that you can presumptively put someone on hormone therapy as long as you are following up on that, I think.
yeah. Yeah, Dr. Rosensweet's a big fan of testing. He repeated it over
Hmm.
and over again. You just have
Yes,
got to test
I
just to be
am
sure.
too.
And I wish I did this more because when I was 50, I did the DEXA scan, see my bone density.
Hmm. Yep.
And every year I do a Dutch test, and I only do it once a year because it's crazy expensive for me, and my insurance isn't covering it. So I do
Yeah.
every year. I'm like, gosh, it's still not really absorbing, and I'm wondering, what do you do for people like me in between? Because I just did a DEXA scan last week, and my bones are in osteopenia, and I'm like, this is. My
Mm.
hormones have not been at the optimal level. I have not, maybe it was enough. I mean, because I didn't have symptoms, which is the problem. So I've been sort of ignored, I guess, by the doctors. Like, I guess you're feeling fine. Well,
Right.
no, so what could I have done? And if there's a woman listening is just like me, what could I have done in between? Because I do is there something else that you can test in between?
Well, I think, I mean, you could do serum testing to look at your estradiol levels because we have ranges for those too. If the urine testing, 24-hour or dried, is not optimal. Um, but I think it also really depends on the route of administration. for what you're getting. We see that sprays are not very effective. We see that creams need a lot more than a gel, than a patch, right? So those regulated doses, like when we look at the patch and we look at gels, they have a much better absorption rate and are able to get your estrogen levels higher than with a spray or a cream.
Mm.
So that would
Yeah, that's why, yeah,
be
the
my
spray was
other
so convenient,
question.
though. I loved
Oh,
it. It
yeah,
was so easy. It dried instantly. But
absolutely.
it
But we
wasn't
find that
absorbing,
it's
yeah.
just not
Yeah.
a great tool. I mean, unless you just need like a fairy dust trickle of estrogen, then this
Yeah.
spray could be helpful. But if we're really looking at supporting you, like we need to understand how creams, like the pharmacokinetics, how those medications affect your body. We need to understand the pharmacokinetics of how cream is absorbed. We need to understand the pharmacokinetics of how a gel is absorbed, and the same thing with a patch, because that, like, just as, I mean, as we hear, right, the dose makes the poison, or the beauty of it, right? So that's where we need to understand not just the modality, so whatever treatment you're using, but also your individuality.
Mm.
And that's going to influence it as well.
Yeah. And not to poo-poo sprays. There's if you're a sensitive type, which I'm not, then
Yeah.
that could be like perfect for you because you
That's
just
why I
need
say,
like
yeah, if you just need
baby
the fairy
doses.
dust, yep, if you need the
Yeah.
fairy dust, it could work great. But if you need like
Yeah.
more intense dosing, the spray may not be your friend.
Yeah. So what I'm doing from now on is getting a little bit more blood testing in between my Dutch and and just to be
I think
sure
that's
I'm
great.
there. Yeah,
Mhm.
because
I think
it's
that's great.
a lot of women I do these reels all over the world. I interview women, I'm asking about menopause, and I meet so many who are like, I didn't go through menopause. I had nothing. I'm like, well, no, you have no period. You are
Yep.
in menopause. Just because you didn't feel it doesn't mean you're not going through it. And in some ways, I think
Right.
it's even more dangerous because then you're not checking, you're not testing, you're not doing anything.
That's
And
right.
then
It's
here
not
you
on the
go,
radar.
yeah, I got osteoporosis or I got heart disease. And where did that come from? Well, this is part of the testing. It's not only about testing your cholesterol.
That's
So
right.
I think women really need to, yeah, you got to have a good doctor really who's who's on board with this. So yeah, get on it. And
I agree.
so let's move
Yeah.
on. One last argument. Um,
Yes.
so I've challenged one of my guests who was dismissing like what I thought was really important is the 2OH, the 4OH, and the 16OH pathways. And of course, there's more of a
Mhm.
story behind them. You can go into it if you want, but just to simplify it, we
Mhm.
mentioned earlier that our estrogen can metabolizing into a quote unquote good 2OH pathway or a bad 4OH, 16OH pathway. And I'm really under quotes because, it's more than that. But
Yeah.
um, in my opinion, like when we take a Dutch test to find out, how our estrogen is metabolizing, I want to know these things. But
Right.
when I asked them a guest about this, they would say, oh, this is still hypothesis. Now, and there we can still mitigate the effects doing other things anyways, just assuming. So w- is this really a hypothesis or how can we prove that it's not just a hypothesis?
So are they saying that the hypothesis is that the 2 and the 4 and the 16OH don't matter?
Yeah.
There's research. There's tons of research about 16OH metabolites compared to the 2OH metabolites and risk for breast cancer. We have uh, not just we, like, there is a lot of research about these metabolites and the balance between the ratios between these metabolites and how it can affect your estrogen metabolism. And when we're talking about estrogen metabolism, we're talking about breast health, ovarian health, uterine health, right? And detoxification in general. So there's research about these. It's not still hypothetical.
You would think if you're going to do this kind of a testing kit, you
Yeah.
you would
Yes.
think, but okay,
Yes.
let's pull out
Yeah.
some of that too. We can put that in the show notes. Um,
Yep.
so this, guest said that maybe it's more important and more accurate to test methylation, which she says can be done with the 24-hour urine hormone test. Does the Dutch test not do that, the methylation?
So it depends on, so the Dutch test is not a true methylation test, right? Like it's not testing true methylation. What it is testing is how your phase 1 clears to your phase 2. And that relies on the COMT enzyme, which is part of methylation, right? Like methylation has multiple pathways that utilizes methyl. We're like we have MTHFR, we have COMT, we have MTRRs, we have multiple methylation pathways. What the Dutch test is looking at is estrogen metabolism through the COMT pathway. So it's not a true methylation test. It is how well your estrogens are methylated.
Mm-hmm.
So
Okay.
it's like an inferred discussion, but I would never say because of your phase 2 metabolism, this means your COMT is or is not working.
Mm-hmm.
We would want to do that through genetic testing.
Yeah. Yeah,
Like you
that's
can
yeah,
you
yeah.
can make summations, right? Like I really do want to look at your COMT because your methylation on this test for estrogen is not good, right?
Yeah.
Like that could certainly be part of the discussion, but I would not be able to discuss the status of COMT or
Mhm.
MTHFR based on the Dutch test.
So is the 24-hour urine test, they do test methylation?
I think it depends on what test you order. So I think you would have to
Oh,
be very specific in what you were ordering
yeah.
for that.
So, because if I were wanting to see my methylation, then I would go, yeah, I mean, we know you could do this through a gene testing, I guess through your saliva. You could do it through, I think it's True Diagnostics. I think they do methylation. That's a blood spot. So you may want to go, okay, if you want to look at that, if the 24-hour urine test does that, well, maybe you could save the genetic testing or save on the, the whole biological age stuff. Or, there's so many ways to skin a cat.
There are, and I think it really depends on what you're looking for, right? Like that's really the question that should be in mind whenever you're testing.
Yeah.
What are the answers that I'm looking for? What are the questions I'm trying to answer?
Yeah, exactly. So, okay, let's move on. There was in our biohacking menopause membership group, which we just launched, and it's now 1 month
Launched,
into it.
yeah.
Yeah.
Congratulations.
Thank you. Yeah, actually, by the time the recording comes out, it'll be 2 months, and the group is
Yep.
growing. It's amazing. And I mentioned to our group that I'm interviewing you, and is there any questions about Dutch testing? And so
Yeah.
we have a couple of them, and one of them is she asks, when can we do the Dutch test, which you answered a lot, but in detail. But she was mentioning her daughter is 15 years old and has heavy periods. We are having trouble getting to the bottom of this, and I was thinking maybe to try the Dutch test. What are your thoughts on this, her daughter?
Yeah, so we do always put the little like disclaimer that for the Dutch test, it's usually adults, so either 18 or 20 years old, but we can still test younger, like adolescent females, um, as long as they have what I would say like normal body weight and they have already been cycling for at least 2 years.
Mm, okay.
So that like we want to make sure that she's had a cycle so that it's not like well she hasn't started cycling and I want to do a Dutch test to figure out why. That is not a good patient for doing testing for cycle. You can still do adrenal, look at that adrenal function, but I'd want her to have had a cycle for at least a year, if not two. Um, and then as long as her body weight, like she has what I would call like an adult profile, normal body
Mm,
weight and size and shape. So because the reason why we generally look at adults for testing is based on creatinine. Since it's a urine test, we have to match that creatinine to the age and sex of the
mm,
person.
mm.
So that is why we have some of those limitations with age. And we are working towards trying to get some good ranges for adolescents, but we just have a lot more cycling females and menopausal females, and
Yeah, well,
we have a
the
lot more of that
adolescents,
data.
yeah, I mean, it's similar to perimenopause, which has been described as puberty in reverse. It's only like
Exactly. Yep. Our second
fluctuations.
puberty.
I-
Totally.
Yeah. So it may be, yeah. So these are good answers. We'll make sure she gets that, because that was a good question. And then of
Yeah.
course she asks, can you do a Dutch test when you were already taking HRT, and any protocol to follow prior to taking the Dutch test. So I think you and I kind of really banged it out. Yes, absolutely. Like when you are on hormone therapy, it's such a great thing to do a Dutch test if you can, or
It
some
is.
kind of looking at your metabolites. Definitely, definitely. But what about the protocol before you take it? Because um, there is a protocol.
Yeah, and it depends on what type of hormone therapy you're taking, right? Like, are you taking topical? Are you taking vaginal? Are you taking oral? Is it a pellet? Are they injections? So there are so many different types of hormone therapies that you can take. And the big ones that have kind of guidelines on them are the oral therapies. So oral estrogen, oral progesterone, oral testosterone, which is not very common, oral DHEA. Like the big ones that we get are oral progesterone and oral DHEA. I would say we get a good mix of topical versus oral estrogen. The reason why oral medications can be an issue with urine testing is once you swallow that, it goes that the liver has to kind of break it down. So you get what's called first pass metabolites, which means you get this big dump of metabolites in the urine. So it makes those levels look really elevated when they're not actually. So there are some guidelines of, hold off on the oral dose for about a day or two, but you would have to look at the instructions based on which hormone you're taking, right? So estrogen versus progesterone versus DHEA have a little bit of a different timeline. And the reason for that is we want to see the metabolite effect versus the falsely elevated effect. And then that gives us a better representation of the dosing that you're taking.
Mm. So if somebody's taking progesterone orally, which is really common and
Mhm.
fine, then, and if they're taking it at night, the day, and you usually start your Dutch test, if I remember, the night before, or like a afternoon,
Like
five
dinner
o'clock or
time.
something like that. So
Yeah,
then you would be, so you're saying, I can't even remember anymore. Yeah. So you're saying don't take the progesterone that night. So if you were on progesterone orally, you would have had it just over 24 hours of the first P.
prior. Exactly. Yep. Yeah.
Okay.
And depending, like if you're the person that's like, well, I'm taking this orally and I'm taking this orally and I'm taking this orally, and there are a lot of questions, that's what we say, just call the lab so we can help walk you through that.
Yeah. But then you would think then if you've kind of if you are not taking your progesterone for more than 24 hours, then how accurate anyways, because you want to see something, some kind of an effect on the body. Because then you're
Yep.
just looking at it, no, if you're not, you're not
It's
taking it.
not
If
no effect though.
yeah,
It's
and if
not
you're
no effect because we're still looking at the metabolites, so the metabolism of those hormones, and that's where we're getting those levels for you. Because if you take it and then you pee it out, you're going to have really high levels.
Mhm.
And so when you skip that dose that night of testing, what we're seeing is really like where the levels lie as your body's metabolizing
So
it.
the metabolites just hang around a little bit longer. You're not
And
like,
they give
because
a better representation. Yeah,
yeah, it must be so complex, this algorithm, because as we know, we take hormones every day, usually. I mean, it
hmm
depends. Some people take them the last two weeks of the cycle if they're still cycling. There's a lot of nuance there, but in
yeah,
general, it's not like you take hormones once a year or once a month. You unless you're on
right,
pellets or something, but you
right,
you know you take it every day because they're gone the next day, right? You have to keep putting it in. And
right.
so so this is why it can be really complex to, I don't know how in the world they came up with this algorithm and how to figure this all out. And I know there's a lot of questions they ask you. So that she asked about the protocol before. There is like
hmm
full page, maybe two, of information that you got to write down all the supplements you're taking and what
When
hormones.
you took it,
Yes.
exactly.
And then
Yeah,
so, it's pretty complex. So I think
yeah.
giving as much information as you possibly can is important. Then there's the whole don't eat avocado thing. What's that
You
all
know,
about?
okay, so this is what I tell people. I know that we say like don't have caffeine the day of testing. Now, this will be to your personal and provider preference. So please talk to your provider, let them know what you're wanting. What I tell my patients is if you drink caffeine every day, keep drinking your caffeine. If that's something that you do every day, keep doing it. I want to see what happens on a daily basis for you. I want to see if that's affecting you, because you also have the people who are like, well, I haven't done the test yet because I couldn't go without my coffee in the morning. Or we've had people that don't take their, caffeine in the morning and they get a migraine, and we can see it negatively affect their cortisol. So if this is something that like you normally do, I tell my patients, stay on your caffeine, right?
Mm,
Like keep doing that. If you have an avocado smoothie every day, keep doing it. If you put bananas in your smoothie or you eat a banana every morning, keep doing it. Like if it's something that you do routinely, I tell my patients to keep doing it. Now, if you don't eat avocados, just try to be aware of that when you do the testing. And if you have guacamole because you guys went out for tacos or whatever,
mhm,
just write it down. What we can see is that these, like the avocado, the bananas, certain nuts, can influence some of the organic acids. And
mm,
so it's good to know that, right? Like, hey, I still drink my coffee, like write it down. I still drink my coffee. My doctor said it was okay. Or I had not, a smoothie with banana in it. That way, when we are, hopefully, when your provider is going through the results, they can say, oh, this could have influenced your dopamine metabolite. So that's what the avocado, banana, and some of
ah.
those food rules are for.
That's right, I forgot there is an organic acid test included
Mhm.
in the comprehensive one, and explain a
Yes.
little bit why you have that.
Yeah, so when Dutch first came out, when we were going through things and, like phase one metabolism, phase two metabolism, would be like, maybe you want to check like a B12 level, or maybe you want to check your B6, or, maybe you should also check this. So we kept saying, like, we'd also want to check this. And so then we were like, it's in urine. We should just add it.
Mm,
So this is where we kind of created what we have now, are like the B12, the B6 markers, the glutathione marker, right? Like make sure that you're checking in on glutathione and detox, biotin, indican. We do have the neurotransmitter metabolites, so the dopamine metabolite, the HVA, and the epinephrine norepinephrine metabolite, the VMA. And though those are neurotransmitter metabolites, they're also really important when we look at overall adrenal function, right? Like when we're looking at catecholamines.
mm.
Um, so, and then oxidative stress, right? Like when we're looking at detoxification, what your body's doing, inflammation, stress response, those are, I think, important considerations when we're looking at them as much as we can comprehensively view. And that's why those organic acids are on there. So it's an
So it's
additional like
if
food too.
I want to go back to a little bit those pathways. If you find out you're a little bit too high in the 16 and the 4-OH pathway, those sort of you're going down not the best road at all. Doctors will prescribe different things. So what
Mhm.
would you prescribe to somebody who is going down those pathways a little bit too much to try to move the marker into a good pathway?
Yeah. So when we look at phase one metabolism, now I always like to look at phase one metabolism with phase two metabolism, because this is like, the bathtub theory and or the filter theory, right? Like you pour your estrogens into that filter, but if you can't get out the bottom of the filter, it's going to clog up, right? So if your phase one metabolism is not happy, we also need to determine, is it because your phase two isn't happy and that's part of it, or is it just really phase one? And so when we look at supporting phase one, which is that 16-OH, the 4-OH, or the 2-OH, things that can really support phase one metabolism in general are things like milk thistle, N-acetylcysteine or NAC, um, sulforaphane, really helpful for that. Rosmarinic acid or rosemary is great. Those are really nice phase one metabolism supports. DIM gets thrown around a lot. I3C gets thrown around a lot. Those are really helpful for pushing things down that preferred 2OH pathway, but you want to be mindful of estrogen levels before you do that. Now, I will say research does not support that DIM and I3C lower estrogen.
Mm.
Anecdotally, what we see is it does
Oh, interesting.
in more cases than not. So that's why I said, I know there have been a couple of supplement companies that have yelled at me because they're like, stop saying that DIM lowers estrogen. The research doesn't support it. And I was like, you're absolutely right. The research doesn't support it. All the research on it doesn't. But anecdotally, all of thousands and thousands of tests that we have seen, more often than not, we see DIM lower estradiol.
Which
So
if you're over and you're estrogen dominant, you got too much of it, well, okay, fine. But if you're just taking hormone therapy like me and you're trying to
if you're already
push it
low,
and you're already low, like
mhm,
that, and I was on dim. This is I'm like, why
yeah,
would my doctor put me on dim? Like she
yes,
and so because I was going pushing down the pathways, and then I found out I was like, wait a second, I shouldn't be taking this at all. So
yeah,
yeah, it's again, it depends who you are and where you're at. Obviously,
that's
listen to
right.
your doctor first, but yeah, you gotta, and that's why in
And
the
just
end,
know too, with something like DIM or any of the things that drive phase one, again, you have to make sure that phase two is open. Because if you're just going to increase phase one, it's just going to create more problems if you can't get rid of phase one metabolites.
and how do you do that?
So, so phase two is all about that COMT methylation. So that's supporting COMT function B6, magnesium, trimethylglycine, possibly SAMe if it's a good fit. Those are the big ones for
Possibly what? What was the
COMT.
last one?
SAMe.
Oh, Sam E. Yeah.
Mhm.
Okay.
Yeah.
And there was also, what about glutathione?
So glutathione, if people will take it, so this is where I have a problem with my patient population,
Mhm.
is they don't like the taste, so they're not going to do it. So I rely on NAC a lot, but glutathione is fantastic for both phase one and phase two.
The taste, but it's just a capsule. No, I mean, how are you delivering it?
So if you are going to do, well, this is my thought on this. If you are going to do glutathione, you want it to be liposomal. If you can find that in a capsule form, great. But if not, it's going to be like the liquid or gel form that you can
Mm.
take. So,
Yeah, yeah. I used to take it as a liquid. No, it tasted okay. But I get to different stuff in Europe than you do in the US. And
yeah.
now
But
I'm
I also think it
taking
depends on the person. Like, I have a friend who loves the taste of sulfury things.
uh
Um, I can
yeah,
take it or leave it. But
yeah.
he's like, oh, this is great. And I'm just like, ah.
Yeah, we're all bio
So,
individual. So
exactly.
I'm on the I found I was I don't know where I was flying through Hong Kong or somewhere. I found glutathione. I was like, oh, great, I'm gonna get it because it's not so easy to find for me. And it was from
Yeah.
Thorne. Thorne, is that
Okay.
liposomal? Do we know?
You know what? I don't know. I would have to look.
I'm gonna double check.
I mean, I would imagine like the general good supplement companies
Yeah.
know the absorbable forms or try to do the absorbable forms. So my hope would be that it is the
I
liposomal form.
I'm gonna go check. I gotta go check. I'm assuming because Thorne is a really good company and they should know
Yeah.
better if they're not.
Yeah. Yes. Or I think reduced glutathione too, because I think oh, like Apex Energetics has their glutathione recycler in a capsule form, and
Mhm,
that one's great. So
mhm.
yeah,
Well, everyone, that's why we test because whether or not the science supports DIM or not DIM or glutathione or not glutathione, whatever, you do one thing, what your doctor recommends you to do, and then you retest and then you see.
exactly.
All right,
Yeah.
all right.
Yeah.
Have you shifted the
You
pathway?
honor your individuality and you honor how your body is going through all of this. And here's the other thing that I want to remind people of is we are not static beings.
Yeah.
We are very dynamic. And so even like once you get to that dose and you're like, ah, and then 3 months later you're like, what? You are a dynamic being. It's totally okay. You are human. And that's why you have, doctors and physicians, practitioners that can work with you on that.
Yes, or you and me.
Yes, yes.
That's what this support group is for. So
That's
one more
right.
question. I know we've gone over the hour, so I'm going to wrap it
Yeah.
up, but
Yep.
one question that is also from one of our members. And she asks if you don't have a relationship with your provider yet on the Dutch testing or urine testing, is there a way to get the Dutch test and then pay for a consult through you because this person, yeah, just doesn't and it's so common. I mean, I don't see there are
I
very
know
few
it really
doctors who
is.
know what to do with a Dutch test. And so what do
It's
you
true.
tell those people?
It's so hard because, yes, you can access a Dutch test on your own as a patient. It ends up being much more expensive, though. And fortunately or unfortunately, the reason why we have decided to do that is to try to get you into a practitioner first so that they can help you maneuver the Dutch test. Now, if you don't have a practitioner and you do end up buying it online, um, the other unfortunate thing is if you want a provider, you can always call our customer service at Dutch, and we have a list of providers that are Dutch
Trained.
knowledgeable, and they can,
Mm,
yep, they can walk you through that. This may depend on location though, depending on where you're at and, licensure and all of that. But as the lab, we have wonderful physicians on staff. The unfortunate thing is we are not legally able to talk to a patient. It puts us at a liability of a doctor-patient relationship, and we can't do that legally. So we are not able to consult as a lab with a patient. And that's why we try to get you into, like, try to find a provider for you that can help you walk through and maneuver the complexities of a
mhm.
Dutch test.
So what I do, I tell my group to contact you to find a provider like that. And
Yep.
I did myself. I'm in Spain now, so I thought, oh, okay, I need somebody to help me through this. And I asked if that the Dutch, I call, Dutch.com, whatever it is, the email, and they sent
Hmm.
me to oh my gosh, it just totally slipped my mind. Nordic Labs. So if you're in
Nordic
Europe,
Labs. Yes.
I'm speaking to the Europeans here.
Hmm.
So you
The
may,
international. Yeah.
yeah, Nordic Labs is .com. You send them an email and then they send you that list of who's around in your country. So that's another way to find it. And I imagine the same thing for people in Australia or Asia.
Yep.
Uh, they could
I
probably,
was going to say we do have different distributors depending on where you are at. So Asia, Australia, New Zealand, Europe. We're limited in Central and South America, but we do have a couple of awesome providers in Central and South America too.
well, you very often, so if you're just looking for someone to interpret it, then you could do telemedicine, go anywhere. However, if you're looking for a doctor to prescribe you hormone therapy, or if you need something
That's
as
a
simple
different,
as DHEA in Spain, it's illegal here. You will not be able to get it. So you need a
yeah.
doctor to help you prescribe you stuff to uh
Yes,
to help you. So then when you go through this list, you got to, kind of filter through it as a doctor. Is it somebody who can prescribe? Because there's a
that's
lot
right.
of, health coaches and people who want to help, and that's great. But if you need somebody to provide, because then you're gonna have to pay two different people.
That's
So
right. Yes, that
so
is
yeah.
true.
So
That's
filter
true.
out, get through that. So I'm gonna have to let you go. We have actually a lot more questions. I'm gonna invite you to our membership group, our biohacking menopause membership group, so we can answer everyone's questions, not just mine.
Great. Yeah, yeah. No, great. I love it.
Yeah, and I'm sending you that calendar. We'll choose a date and really have an hour for everybody, not just me. And if anybody's here listening, you want to join the Biohacking Menopause group, the link is also in the show notes. So before I let you go, is there? I want to let people know also you can find Dutch. I'll have links to the website, but I'll also have links to Dr. Debbie Rice's Instagram account, and you can contact her there.
Yeah.
And sent me you sent me a link to I think one of the publications, from the Menopause Journal. But is there anything else
Gonna have
anywhere
to send
else?
you a couple other links. We're gonna have
Yeah.
lots of information for you guys.
Yeah, send me more. We'll throw everything in the show notes. Is there anything
Yes.
else that I missed that you'd need to tell us about, or where to find you?
I don't think so. DutchTest.com is where you can find Dutch Test, and drrice.debbie is where my Instagram is. And if you have any questions, you can certainly reach out. But I think it might be more productive if we do like the Q&A that you're talking about, Zora. That would be fantastic.
Excellent. Can somebody work with you as a provider if they're in the US?
In the US, it depends on where they're at. So there are some laws. I would say I would probably reach out to me on Instagram and we can talk through what
Mm,
that could look like. Yeah.
okay, great.
Yeah.
And all right, so before I let you go, do you have any last words for women going through the menopause transition?
I would say things that I would like, my one of my really good friends, Dr. Tina Moore, says this: make sure you have your health house in order. And I think that's where we talk about the pillars, like going into menopause. And what that means to me is making sure that you're prioritizing sleep, you're prioritizing moving your body, weight training, yoga, doing physical activity, that you are hydrated, that your blood sugar is balanced and you're not eating a bunch of crap. those are the big things that I would say, and stress management as much as you are able to. Like make sure, like if you want to be successful in transitioning perimenopause to menopause, those things need to be in order. If those are sloppy, your experience will also be sloppy.
Wonderful. Those are great words. Well, I'm excited to have you in the group and thank you so
Yay.
much for your time and we'll see
Thank
you again
you.
soon.
Yes, I'm excited. Thank you so much, Zora.